video, I will deliver a lecture on blood pressure regulation. How the blood pressure is regulated in our body. As you all know, we have systolic blood pressure and we have diastolic blood pressure. So let us, blood pressure, as you all know, it is systolic blood pressure and diastolic blood pressure. Briefly it is called SBP and diastolic blood pressure DBP. Value, if you look at, it is systolic blood pressure 120 millimeter of mercury, and then diastolic blood pressure is 80 millimeter of mercury. Normally this is systolic blood pressure 120 millimeter mercury and the diastolic blood pressure is 80 millimeter mercury. Now the systolic blood pressure actually related with cardiac output and the diastolic blood pressure is related with total peripheral resistance. Let us understand what is cardiac output and how the cardiac output has a relation with systolic blood pressure and the total peripheral resistance has a relation with diastolic blood pressure. Say this is our heart, human heart, and we have the left atrium and we have left ventricle, and this is the major artery. Say it is aorta. I am talking about aorta. Now the pressure present in the left ventricle, it is systolic pressure is 120 millimeter of mercury, 120 millimeter of mercury, and the diastolic pressure is 0 millimeter of mercury. And the pressure in the major artery or aorta, this becomes, systolic blood pressure becomes 120 millimeter of mercury and the diastolic pressure is 80 millimeter of mercury. Now what I am going to say is, at the time of ejection, this valve remains closed, this valve gets closed. Which valve it is? It is the bicuspid valve. This valve gets closed and this valve will be opened. So there is a communication made between left ventricle and the aorta. Once the communication is being made, then whatever the pressure present in the left ventricle is equally transmitted to the aorta. Now here the cardiac output, if we increase the cardiac output, means that we can see at the time of systole. This type of diagram represents the systole present in the ventricle. So when there is a contraction of the ventricle, then the blood is ejected, and the amount of ejection we actually talk about the cardiac output, means the amount of blood ejected either by the left ventricle or by the right ventricle is called stroke volume, and the stroke volume multiplied by heart rate. Stroke volume multiplied by heart rate, that is cardiac output, that will come in liter per minute, and the normal value becomes 5 liters per minute. If stroke volume is 70 milliliter and heart rate is 80, then this becomes 80, or if it is 75, then this becomes near about 5 liter or 5.5 meter. So that is the normal value per minute. That is the normal value, that is the cardiac output I am talking about. Now what I want to say is the cardiac output is stroke volume, systolic blood pressure actually has a relation with the cardiac output. If we increase the cardiac output, we can increase the systolic blood pressure. So systolic blood pressure can be increased if we increase the cardiac output. If we reduce the cardiac output, then the systolic blood pressure will be reduced. Means if we change the inotropic action of the heart, if we increase the inotropic activity of the heart, somehow if we increase the inotropic activity of the heart, we can increase the cardiac output and we can increase the systolic blood pressure. And similarly, if you look at the diastolic blood pressure, when this artery goes in diastole, at that time this valve gets closed. At the time of diastole, we are talking about the aorta. This valve gets closed, means there is no direct relation. There is no pressure present in the ventricle is directly communicated with the aorta. Means totally the pressure in this is totally detached from the pressure present in the left ventricle. So what will happen here? During relaxation, whatever the blood present here, that gives a pressure here, and that pressure we call it diastolic blood pressure. And this diastolic blood pressure has a relation with the total peripheral resistance. That I will tell you with a small diagram. Say this blood actually is distributed to the other arterioles, and say we have the muscles here present in the arteries, and this diastolic pressure will depend upon flow present in the arteries. If flow is greater, then diastolic pressure will be less. If flow is not there, if flow is somehow disturbed, there is no outflow, it is disturbed due to the contraction present in the arterial muscle, then blood will remain here and the diastolic pressure will be increased. So this muscular activity I am talking about, this actually gives the total peripheral resistance. So if we increase the total peripheral resistance due to the contraction of the muscles present in the arteries, then the diastolic pressure will go up. If there is a relaxation with these muscles, then the total peripheral resistance will be reduced and the diastolic blood pressure will be reduced. So there is a strong relationship between systolic blood pressure and cardiac output, and the diastolic blood pressure with the total peripheral resistance. So if we can alter the cardiac output, we can alter the systolic blood pressure. If we want to alter the total peripheral resistance, then we can alter the diastolic blood pressure, because we have a patient maybe hypertensive or maybe hypotensive. In that case, we have to look whether the systolic blood pressure is increased or diastolic blood pressure is increased. If diastolic blood pressure increased, then we will have to put a drug which can constrict the vessels or which can dilate the vessels. Or if there is any problem with the systolic blood pressure, if the systolic blood pressure is increased or it is decreased, then somehow we will have to modify the cardiac output. Means we will have to give the drug which can alter the inotropic action of the heart. Means again I am talking about, if we want to correct the systolic blood pressure, then we will have to concentrate on the inotropic action of the heart. If we want to correct the diastolic blood pressure, then we will have to put a drug which can constrict the arteries or which can dilate the arteries. Accordingly, we can change the total peripheral resistance and we can alter the diastolic blood pressure. Now coming to the mean blood pressure, there is another blood pressure we can have, that is mean blood pressure. Mean blood pressure. Mean blood pressure. Briefly it is called mean arterial blood pressure. Mean arterial blood pressure, there is a formula available in your textbook. That is, I am telling you, that is diastolic blood pressure plus 1/3 pulse pressure. Pulse pressure means systolic blood pressure minus diastolic blood pressure will give you the pulse pressure. So this diastolic blood pressure plus 1/3 pulse pressure will give the mean arterial blood pressure. But there is another formula, that is 2/3 diastolic blood pressure plus 1/3 systolic blood pressure will give the mean arterial blood pressure. Now let us understand about the mean blood pressure. How we can understand about the mean blood pressure? Say I am drawing a line here, and in this line I am talking about the duration of cardiac cycle. Say it is the 0 and this is the 0.8 second. So if it is the 0.8 second, then this is 4 and this is 0.3 and this is 0.8 second. This 0.3 second, this 0.3, that is the systolic blood pressure. This is systolic blood pressure, and systolic blood pressure, it is 120 millimeter of mercury. And then diastolic blood pressure, it is, this is the diastolic blood pressure, and that is 80 millimeter of mercury. How we can calculate the mean pressure? Because first 0.3 second, that is the systolic blood pressure, and next 0.3 second, that is the diastolic blood pressure. We'll have to calculate the mean pressure. So here, if we extend this line, then rest pressure is the pulse pressure, that is 40 millimeter of mercury. So if we can divide this 40 divided by 3, why divided by 3? Because the total duration is 0.8 and the duration of systole is 0.3. So approximately 0.9 second. So approximately this 40 will be divided by 3. We will have near about 13 millimeter of mercury. So this 13 millimeter of mercury plus 80 millimeter of mercury plus 80 millimeter of mercury will give us the mean arterial blood pressure. So that way also we can graphically we can calculate the mean arterial blood pressure. Coming to the another pressure is mean systemic pressure. This is mean arterial blood pressure, mean blood pressure or mean arterial blood pressure, and another is mean systemic blood pressure. That is MSP, mean systemic pressure or mean systemic blood pressure. Now normal value of mean systemic pressure is 6.5 millimeter of mercury, but the mean arterial blood pressure normal value is 92 to 95 millimeter of mercury. This is the normal value. See the difference. Mean systemic pressure, mean arterial blood pressure, already I have told you. The mean systemic pressure, actually it is the pressure, mean pressure of not only artery, it is the mean pressure of capillaries as well as the vein. But in mean arterial blood pressure, we are talking about only the pressure present in the artery. But mean systemic pressure, it is the pressure, mean pressure present in the artery plus capillaries plus vein. Venous pressure, capillaries pressure and arterial pressure. So when heart is stopped, whatever the pressure, mean pressure present in the artery, capillary and vein, that mean pressure comes under mean systemic blood pressure. Mean systemic blood pressure. So if we want to correlate this mean arterial blood pressure and mean systemic blood pressure, then a small diagram, I will have to draw a small diagram here. Say this is the atrium, left ventricle, and here we have to talk about the capillaries, and then vein systems are there. Vein, this is the vein, and then we have the pulmonary right atrium, and this is right ventricle, and this is the blood going to the lungs. So here we have the venous system, and this is the arterial system. This is the arteries. Arteries are there, major arteries are there, and this is the capillaries. So my aim is to tell you the relation between mean blood pressure and mean systemic blood pressure. Mean blood pressure and mean systemic blood pressure. See, this mean systemic blood pressure, try to understand. This mean systemic blood pressure will regulate the venous return. Means this mean systemic blood pressure will tell you what should be our venous return, and the mean blood pressure will tell us about the perfusion pressure. Means how much content will be perfused. That will depend upon mean blood pressure. So just opposite, you can think about the mean systemic pressure will give us the venous return, and the mean blood pressure will give us the perfusion capacity of the vessels. Now coming to the blood pressure regulation. Blood pressure, how the blood pressure is regulated. I have given you just little introductory part about systolic blood pressure and the diastolic blood pressure and the mean blood pressure. How it is regulated? Now regulation, if we talk about, there is a short-term regulation and long-term regulation. The short-term regulation, actually it is neurological regulation. Neurons are involved, but this long-term regulation, this is called renin, angiotensin, aldosterone mechanism. So this is, briefly it is called RAS. Now this short-term regulation, here we'll have to talk about Baro receptor reflex, Baro receptor reflex. Then we have to talk about Chemo receptor reflex. Then we have to talk about volume reflex. Then we'll have to talk about Bain Bridge reflex. Then we have to talk about the Cushing reaction. So I have to explain one by one. First is Baro receptor reflex, then Chemo receptor reflex, then volume reflex, then Bain Bridge reflex, and the Cushing reaction. Let us discuss about the Baro receptor reflex. For this, I will have to draw a diagram. Say this is the heart. This is the heart. This is the heart. We have the 4 chambers. Then Here we have the aorta, and this is the aorta, and here we have carotid sinus. This is carotid sinus, and this is aortic sinus. Now we have to draw the medulla. This is medulla. This is medulla. Then above this we have the pons. Now, if we talk about Baro reflex, then we must come to know where receptor, that is, we call it Baro receptor. What is the location of the Baro receptor? Location of the Baro receptor, it is in case of aortic Baro receptor. Baro receptor, if you want to talk about Baro receptor, this Baro receptor is called high pressure receptor. This is different. This is also having different types. High pressure receptor. This is carotid Baro receptors and aortic Baro receptors. Carotid Baro receptors present in the carotid sinus. This is the color I am using. I am just showing you the Baro receptors present in the carotid sinus, and here this color, this cross, actually I am showing the location of the aortic Baro receptors. This is aortic Baro receptors. Now coming to the another receptor, this is high pressure receptor. This is high pressure receptors. Another receptor we will have, that is cardiac receptors. Cardiac receptors. These cardiac receptors again we will have different types, that is arterial receptors and ventricular receptors. These are low pressure receptors. Means if there is little change with the pressure, say 5 to 7 millimeter changes are there, then there is an involvement of cardiac receptors. But if there is a big difference, big alteration with the pressure, say 20 millimeter mercury, 25 millimeter mercury, 30 millimeter mercury, 50 millimeter mercury, then there is an involvement of high pressure receptors. So this is the classification of different pressure receptors. These are all pressure receptors. Now coming to the neuronal involvement here. Here the ninth glossopharyngeal nerve. This is the nerve ending. This is the afferent. This is the afferent. This is the nerve ending. And this nerve ending, actually, this is the center of the vagus, center of the glossopharyngeal, and another neuron also we have here, that is the vagus. And the center also present in the medulla. Now here what I want to say is there is a center which collect the information about the pressure is nucleus tractus solitarius. This is actually nucleus tractus solitarius, and this nucleus tractus solitarius, another name is sensory area. This nucleus tractus solitarius will collect the information about the status of the pressure. If pressure is increased here, say blood pressure is increased, then what will happen? The pressure will be exerted here, So if this is the structure of the carotid sinus, if this is the structure of the carotid sinus, this is the structure of the carotid sinus, the pressure is exerted here, carotid sinus, and inside we have nerve ending, and all these are connected like this. So here what will happen, say this is the nerve ending, and in this we have the sodium channel. We have the sodium channel. Here we have sodium channel. Here we have sodium channel. Here we have sodium channel. So as soon as the blood pressure is increased, try to understand. As soon as the blood pressure is increased, then there is a stretching, gets stretched, nerve endings are stretched, means this membrane is moved towards this and this membrane is moved toward this. Once there is a stretching, then there is a opening of the sodium channel, sodium ion enters, there is an entry of sodium ion. So if the resting membrane potential is minus 70 millivolt, then this potential will be changed. If we look at the graphs, then in case of action potential recorded in neuron, it looks like this. So there is a potential change, there is a depolarization, and this depolarization comes because of the involvement of sodium channel. Sodium ion enters into the nerve ending, and there is a depolarization. If too many nerve endings are there, then all these potentials will be united, summation will be there, and there is a depolarization, and followed by repolarization will be there. So ultimately what I am talking about, in the nerve there will be a generation of action potential. So this action potential will reach where? Nucleus tractus solitarius. So as soon as blood pressure is increased, then what will happen? We can see the action potential recorded in 9th cranial nerve and 10th vagus nerve. This action potential, this will stimulate nucleus tractus solitarius. So what I have said here, as soon as blood pressure is increased, there is a stimulation of nucleus tractus solitarius. This center will be, this sensory area, not center, this sensory area will be stimulated. Now, there is another center we have, that is cardio-inhibitory center. Cardio-inhibitory center. This cardio-inhibitory center will be inhibited. This cardio-inhibitory center will be stimulated. This cardio-inhibitory center will be stimulated, and this will send the information to the SA node. This is SA node, this is AV node, this is internodal pathways, and then we have Purkinje fibers. So this is the inhibition. This is the inhibition of the cardio-inhibitory center, and this inhibition, this is the stimulation of cardio-inhibitory center, and due to that stimulation of cardio-inhibitory center, and there is a release of acetylcholine from the nerve ending. So acetylcholine release will be increased here. Now there is another center we have. That is cardio-stimulatory center or cardio-excitatory center. This is cardio-excitatory center. Now what will happen? There will be inhibition. This center will be inhibited, negative. This center will be inhibited. Once it is inhibited, then as we all know, we have the sympathetic center. Sympathetic center is located in thoracolumbar region. So here, say this is the thoracolumbar region, thoracolumbar region. So in this we have first 4 segment. Say मान लीजिए this is the first 4 segment which can supply to the heart. So here we have, if we look at the cross section of the spinal cord, here we have dorsal horn, this is ventral horn, dorsal horn, and here we have the lateral horn. So this is the center of sympathetic. So here the center, cardio excitatory center is inhibited. So this will send the information to the lateral horn of spinal cord. From here we have preganglionic neuron, and then we have the postganglionic neuron. So once inhibition of cardio excitatory center, then there is a less secretion of acetylcholine here from the nerve ending, and here it is inhibited, and there is a less secretion of adrenaline here. Once it is less secreted, acetylcholine is more secreted, then what will happen? The heart rate will be reduced. Once heart rate will be reduced, cardiac output will be reduced. Once cardiac output is reduced, the blood pressure also will be reduced. So here, if we want to complete this, the nucleus tractus solitarius is stimulated. I must write it properly. So here, what I want to say is, if the blood pressure is going up, then activity in glossopharyngeal nerve and vagus nerve is increased, and then there is a stimulation of nucleus tractus solitarius. Once nucleus tractus solitarius is stimulated, then there is a stimulation of cardio inhibitory center, inhibition of cardio excitatory center, and there is the inhibition of vasomotor center. So there is another center is there. That is another center also is there. That is vasomotor center. So this is the vasomotor center. This is the vasomotor center, and this center also is inhibited. So what again, if I repeat, once blood pressure is increased, nucleus tractus solitarius is stimulated. Once it is stimulated, the role of this center is to stimulate cardio inhibitory center, is to inhibit cardio excitatory center, as well as is to inhibit vasomotor center. From this vasomotor center, then again, if you remember, there is a lateral horn of the spinal cord, and this lateral horn will give a ganglion, and this will again go to the say this is the vessels, this is the blood vessel, and this will supply to the vessel. This will supply to the SA node. So there will be a less secretion of acetylcholine and adrenaline. Adrenaline secretion will be less. Here also adrenaline secretion will be less. Again, it has a supply to the adrenal gland. This adrenal gland, we have the adrenal gland, medulla is there, which secretes the norepinephrine. Norepinephrine secretion or adrenaline secretion is reduced. Again, it has a role on kidney. This is the nephron. This is the nephron, and this neuron will inhibit the juxtaglomerular apparatus, and there is a less secretion of renin. Means, what I want to say is, this is a reflex process. As soon as blood pressure is going up, then these changes actually will act such a way, so there will be a more secretion of acetylcholine and less secretion of norepinephrine or adrenaline, and ultimately what will happen, the heart rate is reduced. Heart rate is reduced, so blood pressure is reduced. So where how we have started, blood pressure is increased. Now what we are writing, blood pressure is reduced. So the condition, as soon as we can see there is increase with the blood pressure, then the reflex process is adjusted such a way the blood pressure is reduced. So it's a reflex process, and this reflex is called Baro Receptor reflex. Now coming to the opposite scenario, we can have the blood pressure is reduced. If blood pressure is reduced, just opposite way if you can say, if the blood pressure is reduced, then the activity in this neuron is also reduced. Then nucleus tractus solitarius is inhibited. Once nucleus tractus solitarius is inhibited, cardio-inhibitory center is inhibited, cardio-excitatory center is stimulated, vasomotor center is stimulated. So what will happen? Acetylcholine secretion will be less, and the norepinephrine secretion or the adrenaline secretion will be more. The heart rate will be increased, the blood pressure will be increased. So this is also an example of Baro receptor reflex, or we call it Baro reflex. Now coming to the another second reflex is chemoreceptor reflex. Chemoreceptor reflex. Chemoreceptor reflex. Chemoreceptor reflex, if we talk about, next is chemoreceptor reflex. Again, if you draw the diagram of the heart, this is the heart, and we have the aorta. Here in this we have aortic body, and here we have carotid body. This is carotid body, and this is aortic body. And obviously we have the medulla. So what will happen? Here the cell in the present in the carotid body we have, if we talk about chemoreceptor, it is two types. One is peripheral chemoreceptors, and another is central chemoreceptors. Now these peripheral chemoreceptors, where it is aortic body and the carotid body. So aortic body comes under peripheral chemoreceptor, carotid body comes under peripheral chemoreceptors, and central chemoreceptors we have here a center in the medulla, that is chemosensitive area. Chemosensitive area. What is the basic difference between peripheral chemoreceptors and central chemoreceptors? Peripheral chemoreceptors are stimulated whenever partial pressure of oxygen is reduced, partial pressure of carbon dioxide going off, and the pH comes down. But the central chemoreceptors is concerned with the concentration of hydrogen ion. If concentration increases, then the central chemoreceptors also will be stimulated. Now coming to the chemoreceptor reflex. Now this aortic body is made by the glomus cells. This aortic body is made up by the glomus cells type 2. So as soon as partial pressure of oxygen comes down, partial pressure of carbon dioxide goes up, or the pH comes down, then what will happen? There will be a stimulation of glomus cell type 2. Here we have glomus cells type 2. So this carotid body and aortic body contains the glomus cells type 2 will be stimulated. Type 2 will be stimulated. ये stimulate होने से क्या होगा? The information will be carried by the 9th glossopharyngeal nerve, and also the 10th. The information will come to the nucleus tractus solitarius. So nucleus tractus solitarius here will be stimulated, and ultimately what will happen? This will stimulate the chemosensitive area. Now this chemosensitive area, once it is stimulated, as you all know, we have vasomotor center here. We have vasomotor center here. This vasomotor center, this is the vasomotor center. This vasomotor center will be stimulated. This vasomotor center here, it will stimulate the lateral horn, and we have the sympathetic. We have the ganglion is there. This is preganglion neuron. So here it will be stimulated. Here will be stimulated. So there will be secretion of acetylcholine more, and here there will be secretion of adrenaline or norepinephrine. Concentration will be increased. Another function is important here that we must come to know. What is that? That is the respiratory center. We have DRGN and we have DRGN. This is DRGN, this is DRGN, and this is VRGN, dorsal respiratory group of neuron. So once vasomotor center, the function of this nucleus tractus solitarius is to stimulate DRGN. So once DRGN is stimulated, then what will happen? We have increased with respiratory rate, both depth and rate. Means if person is with partial pressure of oxygen, low partial pressure of oxygen, carbon dioxide is more, then the tendency of the person to have both increased with the rate and depth of respiration. So ultimate aim is here nucleus tractus solitarius is stimulated, then there is a stimulation of chemosensitive area, and once chemosensitive area is stimulated, there is a stimulation of dorsal respiratory group of neuron, activity increases and respiratory rate is increased, plus depth also is increased. Depth of respiration is also increased. Means we can consume more oxygen, and we can remove carbon dioxide from our body. So what will happen? Partial pressure of oxygen will be restored, and partial pressure of carbon dioxide will come down. So where we have started? Decrease with the partial pressure of oxygen, increase with the partial pressure of carbon dioxide and the pH. And here just opposite. So this is a reflex process. So this reflex is called chemoreceptor reflex. Now coming to the another important reflex is volume reflex. Now coming to the volume reflex. So here volume reflex. In this again we have to draw the heart. So this is the heart. This is the heart. Here it is right atrium, it is left atrium, it is right ventricle, and this is the left ventricle. We are talking about volume reflex. Now what will happen? If we remember the same diagram I am drawing. So if we increase the volume, which volume? I am talking about blood volume. If we increase the blood volume can be increased by infusion of blood or by infusion of saline. We can increase the blood volume. So if blood volume is increased, then what will happen? The blood pressure also can be increased. Blood pressure can be increased. If blood pressure is increased, then what will happen? As we all know about Baro reflex. But here we are talking about volume reflex. So there is a stretching we can see in the muscle of right atrium as well as left atrium. If there is a stretch, the volume increases here. This will put extra pressure. So there is a release of arterial natriuretic peptide, and this arterial natriuretic peptide, write it properly, arterial natriuretic peptide, and this arterial natriuretic peptide will have an effect on secretion of aldosterone. Aldosterone secretion will be less. Then ADH secretion also will be less. What will happen? If aldosterone becomes less, ADH is less, ultimately urine volume is increased. So once urine volume is increased, then blood volume is reduced. So we have started with blood volume, increase with the blood volume. We have finished with the decrease with the blood volume. It's a reflex process, and this reflex comes under volume reflex. Coming to the Bain Bridge reflex. In this, here the two scientists discovered this. According to their name, this is called Bain Bridge reflex. Here what is happening here, this is the, as we all know, this is the heart, and this is the inferior vena cava. Try to understand what I have drawn. This is inferior vena cava. This reflex can be studied using animal. Which animal? We can use rat, cat, then dog, monkey. But easily available or easily can be performed using cat and dog. So if we put a catheter, here, if we put a catheter in femoral vein, if we put a catheter, see the catheter, all of you have seen, if we put a catheter here, and the tip of the catheter is in right atrium, and if you push with the help of syringe, if we put 10 milliliter saline quickly, then what will happen? We can create pressure in the right atrium, in the wall of the right atrium. Then what will happen? Infusion of saline, say it is 10 milliliter, pressure in right atrium can be increased. So the receptors present in the right atrium get stimulated. Then what will happen? The response means we can see increase with the heart rate or decrease with the heart rate. So this depends upon the initial heart rate. If the initial heart rate is bradycardia type, means heart rate is lower side, then we will have response increase with the heart rate. If already tachycardia is there, increase with the heart rate, then the response will be decrease with the heart rate. So again, if we draw a diagram or the pathway, then in case of decrease with the heart rate, there is a stimulation of vagal efferent, and increase with the heart rate, there is a stimulation of sympathetic efferent. So again, that depends upon the initial heart rate. If initial heart rate is towards lower side, then heart rate will be increased because of stimulation of sympathetic efferent. If the heart rate is towards higher side, then there is a stimulation of vagal efferent. The heart rate will be reduced. This reflex is called Bain Bridge reflex. There is last is Cushing reaction. Here we have the brain, and this is the spinal cord. This is the brain. In any condition, the blood flow is reduced. Then what will happen? There will be a stimulation of sympathetic. Then what will happen? The blood pressure will be increased. Blood flow will be restored. So that is the Cushing reaction. So this is a short story about the mechanism of short-term regulation. And in this short-term regulation, everywhere we can see there is an involvement of nervous system. Because of that, the response becomes very quick. Within a second, we will have the response. Thank you.